Hello everyone, welcome back. So in the last session we have learned about hemodialysis. In today's class we will be learning about renal transplant. So let's begin. So we already know what is renal transplant, right? So renal transplant basically refers to the transplantation of another kidney into someone with CKD or someone with renal shutdown, right? So another kidney or an external kidney is placed into the recipient. So we all have this basic understanding that whenever the body receives something foreign in any form of transplant, be it liver transplant or renal transplant, then your immune system acts against this foreign material. That is the reason why these patients are on lifelong immunosuppressive therapy, right? So the basic fundamental principle of this renal transplant is that you should evaluate the donor and you should evaluate the recipient such that this immune reaction that the body mounts up against the donor's, the transplanted kidney is reduced. Okay. Now, what are the situations where you will require a renal transplant? So, any patient of chronic kidney disease who has been on dialysis or whose eGFR is going down, it is less than 20, then the definitive treatment for this patient will be a renal transplant, right? What are the situations for which renal transplant is being done in today's era? It is being done for diabetic nephropathy. It is being done for chronic glomerulonephritis. Less common causes for which transplant is being done includes chronic tubulointerstitial diseases as well as polycystic kidney disease. Okay. So, what are the things that you have to evaluate in a recipient and what are the things you will have to evaluate in a donor before going ahead with a renal transplant? So, let us look at that. Let us look at recipient evaluation. So, any chronic illness that limits the survival of the patient to less than 2 years, if the patient is not going to survive for more than 2 years, is there a point of doing a transplant for him? No. So, that will be a contraindication. Any active malignancy is a contraindication. So, many of the malignancies have a waiting time, okay, except basal cell carcinoma. Basal cell carcinoma does not have a waiting time. You can still go ahead and do a renal transplant. Uncontrolled psychosis. The patient has to be in a proper frame of mind and proper functioning of your psychological mind before going ahead with a transplant. Then the most important thing, contraindication would be a HLA mismatch. So, what are the matches that you need to look for in renal transplant? So, there are two classes of HLA. HLA basically stands for human leukocyte antigen. Human leukocyte antigen, which is present on chromosome number 6. So, before you receive an organ or kidney from someone, there has to be some amount of matching with respect to this HLA between the donor and the recipient. The reason being, if there is a HLA mismatch, then our body is going to mount up a huge immune response against the foreign HLA molecules. Okay. So, HLA class 1, you are looking at A, B and C. Under HLA class 2, we are looking at DR, DP and DQ. Okay. So, the minimum amount that is required is a 3/6 match. Okay. That means that at least 3 out of these 6 parts of the HLA should be matched. So, 1, 2 and 3/6 match are high risk transplants. They are high risk transplants. High risk in the sense, high risk of what? High risk of rejection. High risk of our body rejecting the transplanted kidney. Whereas 4/6, 5/6 or 6/6 are good. They are good or they are low risk transplants. Okay. So, if you are obtaining a kidney from one of the parents, then you will have a 3/6 match. If you are obtaining a kidney from your identical twin, then you can have even a 6/6 match. Okay. So, this transplant can be from a living donor, it can be from a related donor or unrelated, right? We have transplant registries where all these HLAs are entered so that even from an unrelated donor, you can get a good match. Okay. But in your living donors, the probabilities are like this. In your living related donors, your probabilities are like this. Okay. So, this is about your HLA matching for transplant. Now, what are the things that you have to evaluate in the donor? What are the things that you have to evaluate in a donor? You have to see if the donor is fit for donation of the kidney as well. So how is the donor classified? Live related, live unrelated and cadaveric. Cadaveric transplants are not frequently performed. What we prefer are the live related or the live unrelated, right? So what are the things that you have to look for? You have to look for comorbidities. The patient should not have, the donor should not have any comorbidities, diabetes, hypertension or any other comorbidities such as ischemic heart disease. All of these are contraindication to be a donor. Why is that so? Because many of these comorbidities predispose the individual to calcification of the vessels. If the vessels are calcified, then you cannot transplant that kidney because those vessels are sutured to the native vessels. So if they are calcified, then the chances of rejection is more. That is why it is a contraindication. And the vasculature has to be normal. So a donor basically undergoes a complete series of tests, and he also undergoes testing such as renal artery Doppler to see if the vasculature is normal. Okay. Then donor should be free of malignancy, hepatitis or HIV because there is a large risk of transmission of these infections to the recipient. Okay. So what have we learned till now? We have understood what is a transplant, we have understood the indications, we have looked at how do you evaluate your donor and how do you evaluate your recipients. Now let us understand what is the absolute contraindication for a transplant. So the absolute contraindication, because the highest fear or the biggest fear that we have about any transplant is rejection, right? So we go to any length to avoid these rejections. So the absolute contraindication is the presence of this anti-HLA antibodies, right? So we already discussed that you need to have some amount of HLA matching. You need to have ABO matching as well, which is your blood group matching, but HLA matching is more important. Sometimes even non-related blood groups you can do a transplant. So the most dreaded thing is your presence of anti-HLA antibodies. So if the recipient has anti-HLA antibodies to this donor, then that donor cannot donate his kidneys. Okay. So what is the test that we use to identify this anti-HLA antibodies? We use the CDT test, which basically refers to complement dependent cytotoxic test. Complement dependent cytotoxic test. So what do we do in this? We take the recipient's serum and you take the donor lymphocyte. You take your recipient serum and you take your donor lymphocytes. So what happens is that this will have preformed anti-HLA antibodies. It will have preformed anti-HLA antibodies. So if there are preformed anti-HLA antibodies, then this is going to react with the HLA antigens on the lymphocytes and the test will come positive. If the CDT test is positive, then it is a contraindication for renal transplant. Okay. So this is your absolute contraindication for renal transplant. Now let us understand how do these rejections happen. So first thing is that, so you have your allogenic antigen presenting cells which are from the graft. So these basically engage the CD8 positive T helper cell. So there can be allogenic antigen presenting cells which engage the CD8 positive T helper cells, and the activated T cells are responsible for the cellular rejection. So we know that there are two types of rejection. You have your antibody mediated rejection and cell mediated rejection. So this cellular rejection is brought about by allogenic APCs which are from the graft, which engage the CD8 positive T cells and cause rejection. Then the allogenic antigen presenting cells can also engage the CD4 T helper cells. If they engage the CD4 T helper cells, then cytokines are produced. The cytokines then activate the T cells, or they can activate the B cells to produce antibodies. They can activate the macrophages, and which in turn stimulate the B cells to produce antibodies. And this is how you get an antibody mediated rejection. Okay. This is how you get your antibody mediated rejection. Then you have an indirect mechanism. The indirect mechanism of rejection is your self-derived antigen presenting cells in the recipient the self-derived antigen presenting cells in the recipient, which can cause a delayed hypersensitivity reaction. So this is how the different types of rejections happen. So you have your cellular mediated rejection, you have your antibody mediated rejection, and you can have an indirect pathway as well. Okay, fine. Now let us understand more about T cell mediated rejection. Well, let us understand more about T cell mediated rejection. So in T cell mediated rejection, what happens is that the recipient T lymphocytes interact with the donor HLA. The recipient T lymphocytes basically interact with the donor HLA, right? So if this interaction happens, the recipient T lymphocytes basically interact with the donor HLA. Now, they can engage the CD4 cells which interact with the HLA-DR, or the CD8 cells which basically interact with the HLA-A or HLA-B. Fine. So first step is that there is engagement of the co-stimulatory molecules. So the first step in this T cell mediated rejection is the engagement of the co-stimulatory molecules. So on the T cell you have the CD8 positive molecule, and on the antigen presenting cell you have this CD8086. So this interaction between your CD8086 and your CD28 on the T cells and CD8086 on the antigen presenting cell causes activation of calcineurin pathway. Now this calcineurin pathway in turn causes stimulation of interleukin 2 and interferons, and this in turn causes stimulation of your mTOR pathway. Okay, this in turn causes stimulation of your mTOR pathway, which finally results in your T cell mediated rejection. Okay, so what are the steps and what is the part of your T cell mediated rejection? So what are the steps and what forms the part of your T cell mediated rejection? Recipient T lymphocytes basically interact with your donor HLA, right? So that means that they have what? The recipient T lymphocytes are activated against your donor HLA. So the CD4 T cells interact with HLA-DR, CD8 interacts with HLA-A or B. Then there is engagement of the co-stimulatory molecules. These T cells get activated and they interact. The antigen presenting cell presents these antigens, HLA antigens, to the T cells through this CD8086, CD28 interaction. The T cells get activated, they stimulate the calcineurin pathway, interleukin 2 interferon and mTOR pathway. So on histology, the hallmark of histology findings in T cell mediated rejection is that there is interstitial inflammation, tubulitis and vasculitis. There is interstitial inflammation, tubulitis and vasculitis. Now let us understand B cell mediated rejection. In B cell mediated rejection, there are donor specific antibodies which go and activate the complement system. Right, so there are donor specific anti-HLA antibodies which go and activate the complement system. So the histologic footprint, or when you do a renal biopsy when you are suspecting rejection, if it is a B cell mediated rejection, you find this C4D positive staining in the peritubular capillaries. You find this C4D positive staining in the peritubular capillaries. Okay, so this is about your T cell mediated and your B cell mediated rejection. So in your T cell mediated rejection, the histological finding is your interstitial inflammation, tubulitis and vasculitis. In your B cell mediated rejection, you have the characteristic C4D positive staining in your peritubular capillaries. Okay, so till now what have we learned? We have understood what is the absolute contraindication for renal transplant. It is the presence of preformed anti-HLA antibodies. We have understood the mechanisms of T cell mediated and B cell mediated rejections, and what are the characteristic histological findings in each of this. Now, let us understand how do the patient present and how do you manage. So, how does the patient present? So, when do you think that there is a rejection? So, what happens is that there is a rise in the creatinine, right? There is a rise in the creatinine, there is a decrease in the urine output, there can be hematuria and there can be a renal shutdown. Right, there can be a renal shutdown. So these rejections can be hyperacute when it happens in the OT table or immediately after the transplant, or it can be acute or it can be chronic. Acute is up to maybe 4 to 6 weeks and chronic is when it happens beyond the first 2 months of transplant. You have a chronic rejection. Okay, so how do you manage these rejections, right? So how do you diagnose it first of all? So whenever you are suspecting a rejection, especially in a post-transplant patient, you will have to do a renal biopsy. Your characteristic histological findings will help you differentiate whether this is a T cell or a B cell mediated rejection. So once you find out that in a T cell mediated rejection, you will have to give high dose methylprednisolone along with anti-thymocyte globulin. Okay, ATG stands for anti-thymocyte globulin. In your B cell mediated rejection, since it is antibody mediated, you can use PLEX, which is your plasmapheresis or plasma exchange. You can use IV immunoglobulins or you can use rituximab as well. So PLEX and IVIG forms the cornerstone treatment of B cell mediated rejection. For T cell mediated rejection, you use methylprednisolone with ATG. Okay, fine. So till now, what all have we learned? We have learned about the various types of rejections. How do you identify rejections? How do you treat these rejections? How do you do a recipient evaluation? How do you do a donor evaluation for renal transplant? Now, like I had told you, if you are getting a foreign kidney, then you have to be on lifelong immunosuppressive therapy. So every transplant recipient has to be on a lifelong immunosuppressive therapy, right? So how do you determine what type of immunosuppression they have to be on? So first thing is that you check whether this is a high risk transplant. So what are the features of your high risk transplant? A high risk transplant has a high titer of panel reactive antibody. That means the titers for this antibody, which basically predicts. So we do a number of tests, right, before the transplant. So if there is a high titer for a panel reactive antibody, high titer panel, that means that there are HLA antibodies which are formed. Then this is a high risk transplant. If the patient is a recipient of prior transplant, if the patient is a recipient of autoimmune glomerulonephritis, because if there is a risk of autoimmune glomerulonephritis, then you can have a higher risk of rejection. The donor's age is more than 60 and the donor's cold ischemia time more than 24 hours, right? So when you are doing a transplant, the kidney is bought in a cold storage, right? If the cold time is more than 24 hours, then it is a high risk transplant, right? So what are the features which make the transplant high risk? So we have a high titer panel reactive antibody, recipient of prior transplant or a recipient of autoimmune glomerulonephritis. The donor factors include donor age more than 60 or cold ischemia time more than 24 hours. So if this is a high risk transplant, then you have to do an induction. You have to do an induction with the high dose immunosuppressive agents such as anti-thymocyte globulin with steroids, and you continue them on lifelong calcineurin inhibitors. If it is a low risk transplant, then you do a basiliximab induction. What is basiliximab? It is an interleukin 2 inhibitor. So you can do a basiliximab and steroids and continue with calcineurin inhibitors. Okay, so this is about your immunosuppression in transplants. So what are the other drugs which can be used? Patients can be on lifelong immunosuppression. They can be on CNI, which is your tacrolimus, right? You can also be on mycophenolate mofetil. So these are the other immunosuppressants which can be used. Now, we have understood what are the types of rejections. We have also understood how do you manage the different types of rejections and how do you maintain and what are the induction and maintenance immunosuppressive regimens. Now, let us understand that whenever you are doing a renal transplant, when the patient is on immunosuppressive, that means that his immunity is very poor and he is always at a risk of post-transplant opportunistic infections, right? OIs. And the timing at which these OIs happen is very, very important. In the peri-transplant period of less than 1 month, what are the type of infections that are expected? You can have wound infections, you can have surgical site infections, hospital-acquired infections, UTIs and so on and so forth. Then herpes and oral candidiasis. In the early post-transplant period at 1 to 6 months, what all can you have? You can have PCP infections, CMV, Legionella, Listeria and hepatitis. In the late transplant period more than 6 months, remember the fungi which is your aspergillus, and the most important virus is your BK polyoma virus. So this BK polyoma virus is a very important virus which is associated with post-transplant polyoma nephropathy, where you can have renal failure. And in the urine, what is the characteristic feature of the urine analysis in BK virus infection? It is your decoy cells. So whenever you suspect a BK virus nephropathy in a post-transplant patient, the treatment. So whenever you suspect a BK virus nephropathy in a post-transplant patient, the treatment will be to reduce the immunosuppression. It will be to reduce the immunosuppression. Apart from this, in the late transplant period also, you can have herpes zoster and hepatitis infections. Right. So this brings us to the end of this session on renal transplantation. So I hope you have understood what are the most salient features of renal transplant and what are the complications of renal transplant. Thank you.